Hello, everybody. I'm running a couple minutes late, but I am here. For those of you watching the replay, please put replay into the comment section. I really appreciate when you guys do that. It helps me kind of keep track of who's watching. And also, if you, those of you watching the replay, if you have any questions, go ahead and put them into the comment section. I do go back after the show's done and I check back to see any questions that I may have missed or any questions that were on the replay. So we've got we don't have quite as many questions tonight, but they're really great questions. So I'm going to give you guys a minute or two to jump on board. And I am actually trying to call up this phenomenal website that I will be talking about tonight. That is an amazing resource for the limb loss community. Hey, there we go. There's Harsh. Hey, there's the wonderful Mark S. Compadre, how you doing, man? Megan, so glad you could join in. Thank you, Frank. I'm excited too. Hey, William Mays, you're on board. All right, we got Barbara Schweitzer. Ooh, she's got a nice little purse emoji. She always has like the best emojis. I love it, Barbara. Thank you so much. And Barbara's watching me from my YouTube channel. So folks, just so you know, I am streaming both to my Facebook channel and my YouTube channel, everything under the name of Cosi Talks. I like to make it easy. For folks who don't necessarily have a Facebook account or don't necessarily like using Facebook, to watch the live shows. So you can catch me on either channel. Hey, Kenny, what's going on? Johnny V, what's going on, man? We got Brett Sykes with his iced tea, Brian Bishop. Brett, man, I tell you what, I could use a glass of iced tea right about now. I just came back from my daughter's swim meet. Her high school swim meet. I'm so excited. My oldest kid is in high school and she's doing swim meets and all that kind of fun high school stuff. Hey, Chuck, what's going on? Hola. We've got Brian Bishop on board. All right, guys. So like I said, not quite as many questions this evening that came in this week, but the questions that did come in, good ones. Really good ones. Let's see, we got Jim Simpson on board. All the best with St. Louis. Oh, thank you, Jim. And we've got Linda. Thank you, Linda, for joining in. All right, I'm going to give you guys another minute or two to jump on board. So guys, let me see a show of hands. Who's going to the Amputee Coalition National Conference? Who's going? Show of hands. Hey, comadre, what's going on? All right. So, all right, we got a good group on board tonight. I am expecting a couple of new people to join in tonight. So if you are new to this show, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for a little over 18 years, and my passion is working with the limb loss community. I have a clinic here in Tampa, outpatient clinic that is exclusively for working with amputees. And we've got lots of exciting things coming down the pike for Cosi Talks as a show, as a business. There's a lot of exciting things going on in the next 2 months. So I can share with you guys November 3rd. That's all I'm going to give you right now. Write that date down on your calendar. It is a Wednesday night. It's on my Wednesday night show, November 3rd. Okay. That's when you guys are going to finally hear about this big top secret project that I've been working on for almost 2 years now. November 3rd, guys. Okay. So let's see what's going on. Let's see. Brian Bishop got a scholarship for virtual. Good. Brett is not going. Johnny is going. William is going. All right. So Jim is going as well. So guys, I'll be saying this throughout the night just because I'm so excited to finally share this with you guys. November 3rd, big launch date for the thing I've been working on for 2 years now. And there are some of you out there who have been helping me test it out, who are going to be helping me test it out. So shh, mum's the word. All right. Big party going on the Cosi Talk show, November 3rd, guys. So write that in your calendars. November 3rd, you want to be on this show watching. Pam, how are you doing, Pam? I've got your question here. And Pam, I even have Bob helping out with the demonstration. All right, let's get started with some of these questions, shall we? All right, Pam, let's just tackle your question first. Let's do this, Chica. All right, so Pam asks, ischial containment versus sub-ischial containment sockets. Can you explain the difference and how you determine which is best, right? I got you, Mark. I got you. Right. So guys, sockets nowadays come in all sorts of shapes and flavors and sizes and materials and adjustability and all that kind of good stuff. Okay. So we have an evolution. I did a show once a couple of years back on kind of like the evolution of the socket. Basically, the shape of the socket has changed. It underwent a dramatic change in the 80s, right? It used to be like this big square kind of quadrilateral socket, and then it got narrowed and squished a little bit to this current socket that we have nowadays. Hey, Van Gregory. Oh, you got the K3 eval this week? I want to know how that goes, Van Gregory. I want to know how it goes. So I literally just dusted this thing off. You can tell how old this socket is. It's a very, very old socket. Okay. So when we talk about ischial containment, right, that's kind of one of the big changes. I think it was either in the 80s or 90s that came about the socket. Bob here is going to demonstrate. Okay. And sorry, Bob, you're not going to like this. So guys, your ischial tuberosity, right, is right here. It's basically your butt bone, and you have two of them. Okay. So when you're plunked down in a chair, those two little bones that you're sitting on, those are your ischial tuberosities, right? So when you are being fit for an above the knee socket, right, there's two basic choices. Ischial containment, okay, which means the socket comes up on the back and it contains your ischial tuberosity, okay? You have ramus containment, right? The ischial ramus, which is this front part here, the front part of the pubic bone, that also gets encased in the ischial ramal containment socket. And then you have sub-ischial sockets. So what that means is sub, underneath, meaning the trim lines of the socket start maybe around here, meaning they do not contain, get your arm out of the way. They do not contain the ischial tuberosity. They do not contain the butt bone, okay? So here, sorry about. So here's an example of an ischial containment socket, albeit a very, very old one. Okay, so with this one, yeah, I got it the right way. You can see right here the back part, the brim, right? And with the ischial containment, the ischial, the tuberosity, the bone itself is meant to kind of sit a little bit on this brim, and it's meant to take the weight of the body, okay? Now, the thing with the ischial containment or ischial ramal containment, depending on if you're also containing the front part, okay, is that the trim lines are very, very high, right? They're all up in the good china. So it can be a little bit uncomfortable, actually a lot of bit uncomfortable, okay? And I was actually having the conversation with the prosthetist not too long ago, actually the prosthetist that I stole this socket off of. Sorry, Mike, I gotta get this back to you. But he was saying, you know, he's like, people who are actually in a true ischial containment socket really aren't that many. A lot of people say they're in ischial containment sockets, but when you look at their butt bone, when they stand up, their butt bone is not all the way in there where it should be. And the reason is because, yeah, it's a little bit uncomfortable. It's basically like the equivalent of having someone have the heel of their hand right on pushing up on your butt bone. It's not painful, at least it's not supposed to be painful, but it is an uncomfortable feeling that you have to get used to it, okay? So why would anybody want the pressure right up on their butt bone with this kind of a socket? It provides the most stability, guys, okay? The higher up you go on these trim lines with these sockets, the more stability you're going to get, okay? And here's why. Come here, Bob. All right, when you have a full length leg, right, the full leg, part of what this tibia here, this lower part is doing is that it's stabilizing your femur, right? So when you have an amputation across the femur, that femur is now free floating. So you need the stability of a socket, right, to clamp here, and clamp that femur to be stable and not flip-flopping around, right? Not bell clapping around, which is what happens sometimes when these sockets are not fit properly, okay? So the higher up you go, the more stability you're gonna have. Now, let's switch it around just a little bit. Let's talk about the sub-ischial socket. And I don't have an example of that one right here. Those are still kind of relatively new, meaning they came out after I became a therapist. They came out a little bit later, right? And we're starting to see more and more of those pop up. So with the sub-ischial socket, you know, the trim lines don't go up to here. They go here, okay? So as you can see, the whole pubic ramus, that area up front is free floating, and the area in the back, that butt bone is out in the open, okay? So the obvious benefit to that is you don't have the socket pushing up in all of, you know, the china part. So it's a little more comfortable, right? You have a little bit more movement available, right? The downside is you got a whole lot less stability, okay? You don't have something that's clamping that femur down as sturdy as one of these, okay? So Here's who I think, and actually I had John Hatting. He's an amazing prosthetist up in Virginia, and he came on the show because he does sub-ischial containment sockets. Here's the thing with sub-ischial containment sockets, because they became very popular, very trendy for a while, and I started getting a lot of questions from folks who thought they needed to get a sub-ischial containment socket because they didn't want to have that socket all the way up in their groin, which is understandable, okay? But here's the deal. Those of you who are walking a lot, those of you who are my above the knee amputees and who are experienced walkers, you know that you need to have good solid glute strength, right? To power your prosthesis. You need to have that glute strength to stabilize that pelvis and to give you power. Otherwise, you start getting all these gait deviations, right? So those of you know that. So, and you also know that you have to use it or lose it, meaning you have to do some sort of maintenance on your glute strength, whether it's exercising, walking, staying very active in your day, okay? When you have a sub-ischial socket, you really need to work on the glutes because the glutes are taking that much more of the slack. They have to do that much more powering, right? To keep you stable in that socket. Okay. And this is where I run into a lot of problems with many folks who go and they try to get a sub-ischial socket and they realize it's not working for them. Number one, because they don't train their glutes and they don't strengthen those glutes enough to be able to stabilize in that socket. The number two reason I see for people who end up not having good outcomes with sub-ischial sockets, they don't have a trained prosthetist. Okay. And guys, this is not a knock against prosthetists. We have some amazing prosthetists, but in order to do a well-fit, stable sub-ischial containment socket, you need a prosthetist who's done several. And John Hatting, the prosthetist I just mentioned, he was on the show and he said the same thing. He said, you need to ask your prosthetist, how many of these have you fit? How many of these have you made? Okay. And I've had one of John's patients who had a sub-ischial containment socket and it fit her beautifully. Okay. And then I had another patient from a different prosthetist who was just starting out and learning how to do the sub-ischial sockets, and we had more problems. And it's not to say that prosthetist didn't eventually learn, but meaning you need to get a lot of experience with that. And it's something that your fit also has to be stable. Okay. One patient who had a sub-ischial socket, that it fit her very beautifully in the beginning, but her limb volume started changing a lot. She started shrinking a lot. Okay. And she wasn't able to go back to the prosthetist as often as she could. So it made for an unstable fit very quickly. Okay. How many of you guys here, show of hands, guys, how many of you who has an ischial containment socket and who has a sub-ischial socket? Can y'all put that into the comment section? I'm going to review some of these comments that came in. Let's see. Oh, Brian, that's a good question. Brian, I am going to come back to that question, okay? Hey, Lanya. Oh, I'm so glad you're here. We got Alex on board. Thank you, Alex. Good China. Hey, Mark, you know, I'm a mom of four. I have different ways of saying, you know, private parts. We say the good China in our household. All right, Bonnie says, hey, Cozy, stood on my stubbies for the first time. Yes, the first time she stood in over 3 years, Bonnie. That is wonderful. Wonderful, Bonnie. I am so glad to hear that. Thank you for sharing that with us. Bonnie, if you ever get a video done of that, I would love to see a video of you walking. Just saying. Hey, Stephen, thank you so much. Hey, Joe, we got Keith from Myrtle Beach checking in. Wonderful. So Brett has an ischial containment socket. Pam has ischial containment up in my China. Guys, that's probably going to become another one of my catchphrases, right? It's all about the butt and it's all up in the good China. So yeah, guys, and it's not to say that you can't play in between. Like I said, the majority of people who tell me they have an ischial containment socket, when I stand them up in the parallel bars, I'm like, that ischium isn't in there. But it's not to say that it's not working out for them, okay? There's a lot of wiggle room in between. So usually my general rule of thumb recommendation is that unless you're like a 20 or 30-year-old athlete, right? Some, you know, big buff and juicy, muscly athlete, start off with the fuller length socket, okay? Your prosthetist can always trim down the trim lines, okay? But you can't add to the socket. And I hear this also from my prosthetist too. They'll say the same thing. Hey, Marianne, that, you know, if a prosthetist has a patient whose socket is a full length, then they can trim things down little by little. But once you make a sub-ischial socket, I mean, that's it. If it's not working out for the person, they have to go through the process of getting a whole nother socket approved. Does that make sense, guys? And I do have some folks that they learn how to use the socket. And yeah, the part, especially in the front part, for the men and the women alike, gets a little bit uncomfortable. So the prosthetist can kind of bend things around. Here's another example. Here's the front part. You know, where the prosthetist can play around with the inner flexible lining. You know, you can see here that the inner flexible lining is extending up out. So it's not, this part is not hitting right on the skin, right? To make it just a little bit more comfortable, a little bit more bearable. This part down here gets flared out. The part that's in the groin area just gets flared out just a little bit for more comfort, okay? But usually, as far as when folks come in for recommendations for me, I very rarely recommend a sub-ischial socket. If I do, it's usually for my younger folks who are athletes and very active, and they're constantly doing a good strengthening routine. Okay. All right. So, you know, Pam, if this is something that you're thinking about, and Pam, I don't know much about your case or, you know, what your level of fitness is right now. But I would just say, you know, just start off by having your prosthetist maybe trim the lines down just a little bit and just see how you feel. And if you feel like you're really you lose some of that stability, then, you know, that's your answer right there. If you feel like you're still stable and your gait isn't doing anything funny or funky, okay, then, okay, maybe you can trim it down just a tiny bit more, right? Hey, Daniel. Aw, Doug. Love having my Canadians on board. So Jim has an ischial containment. Okay, good. Yes? Okay. Anybody here have a sub-ischial? Anybody? Anybody? No? Crickets chirping? Okay, we'll move on to the next one. All right, guys. Shameless plugging again. November 3rd, guys. November 3rd. Big party here on COSI Talks. Big, huge announcement about my top secret project. It's going to be launched November 3rd. And here's another part of it. Ooh, guys, I know I'm being absolutely terrible tonight. If you haven't already done so, please sign up. Pretty please, with a cherry on top. Sign up for my email subscription list. I put the link right there. It's on my website. The people who are on my email subscription list, they're going to get a sneak peek as to what this top secret project is before everyone else. So before November 3rd, they're going to get access to it. So if you're not one of my email subscribers already, subscribe now. Do the right click, subscribe, get on my email list. I promise I don't spam your mailbox and all that kind of funny stuff. All right, next question. This is a good one. So Felicia, I had a lovely conversation. Oh, Marianne, this is just another run-of-the-mill socket. It's just a socket. I actually kind of went rummaging through one of my favorite prosthetists. Every prosthetist has a dusty old closet. I don't care how fancy their clinic is. Every prosthetist has a dusty old closet where they have dusty old sockets and, you know, dusty old feet for nosy physical therapists like me who go digging through it and swiping some stuff. Mike and Gina, I promise I'm going to get you back these sockets. But no, Marianne, it's just another socket. And it looks like this one had a window put into the back of it for some pressure relief. So yeah, just run-of-the-mill socket. Looks like it was an ischial containment socket. It goes up pretty high right there in the back. Okay. Brett says, cool kids are email subscribers. That's right. Cool kids are email subscribers and they have a coffee mug. Don't you hate people who are constantly promoting themselves? All right, guys, next question. This one came from Felicia, and I had a lovely conversation with Felicia this week. She says, I've been denied for a particular microprocessor knee. And she went ahead and named the knee. And she said, I believe in one of your videos, you mentioned someone who can help. I guess I should have started. I'm a left above the knee amputee as of March of this year. I'd appreciate if I get some information on who can help. We are currently in the appeal process, but any help would be appreciated. Now, those of you who have been watching the show for the past, those of you who've been watching the show for the past couple of weeks, I've been talking about the K levels, right? How as an amputee, you are assigned a K level depending on your level of mobility. And the whole purpose of the K level is to submit it to your insurance company along with the prosthetic device that you are requesting. So depending on the K level that you are will determine what kind of a prosthetic device you will be approved for, or so the saying goes. Now, for this particular individual, she was tested, and she was tested to, in fact, be a K3 level, right? So technically, as a K3 amputee, you are able to do ambulation in the community. You are able to vary your cadence, meaning you're able to walk fast, you're able to walk slow, depending on what the situation calls for, right? So a K3 ambulator is a pretty active individual as an amputee. And if she, in fact, did all the functional testing correctly and tested as a K3 level, she's a great candidate for a microprocessor knee. Apparently, the insurance didn't think so. And the insurance, I believe, told her that it does not necessitate a microprocessor knee because it doesn't improve the quality of her life. Yeah, that's what I said. And I went on to ask a little bit more about this individual, and it turns out she has a very active job, a job that requires her to be getting in and out of a car all day long, visiting client homes in and out of places. And this is a very active, younger individual. So what's a girl to do, right? Well, went to my friend, Julie Conley. And I don't know if you guys remember, this was probably a year ago. Okay. I had Blatchford Company on board sponsoring a show, and they introduced me to this lovely individual, Julie Conley. Julie is also an amputee, and she has this amazing story that she told on the show. And I'll try to get the link and post it on here afterwards if you guys want to watch the show again. So she tells her story, and she tells of how she wanted to trial the Elan, which those of you who might remember, the Elan is the microprocessor hydraulic foot ankle system by Blatchford. Beautiful foot, beautiful foot. She tried it and loved it. I mean, to the point where she said, I feel like I almost have my natural foot back for the first time since amputation. So needless to say, her quality of life was about ready to go up, and her insurance denied her, right? So she literally took it to the top. She went to the top of her insurance company, went through the whole process, and got it approved. And since then, Julie has been helping other amputees do the same thing. In fact, please hold. Julie started an organization. And her organization is called Amp You Up. And this is the website, ampyouup.org. Okay. So for free, if you've had your prosthetic device denied by your insurance company and you feel like you have a case that you really truly are the ideal candidate for the particular prosthetic device, you can go and submit your story here to ampyouup.org. And they will review your case. They will assign you someone to work with and to see about getting you approved for this case. That's pretty awesome, guys. And Julie is someone who's helped out on more than one occasion, many success stories. She was actually telling me a success story today that just completely blew my mind with a particularly challenging insurance company that will remain nameless. And she won the case for this gentleman, and he was able to receive the prosthetic device that was allowing him to get back to his very active sports lifestyle. Okay. So guys, there's no guarantees in life. There are no promises. But when I see a resource like this, it's just like heaven opening up, floodlights everywhere, angels singing, right? So if some of you have been denied, and let's do another cozy poll. How many of you guys have been denied a prosthetic device? Show of hands. I know that I should be getting a lot of comments in this section right here. I know, Mark, the Elans are pretty nice. I should be getting a show of hands in the comment section right now. How many of you have ever been denied a prosthetic device? Whether it was getting a microprocessor knee or a microprocessor foot or a dynamic response. Megan's been denied. Mark's been denied. Yep, Pam's been denied. Come on, don't be shy, guys. Joe's been denied. Jim, no? Okay, you're one of the lucky ones, man. You're one of the lucky ones. Brian's been denied, right? And guys, it's not a perfect system. We talked about Diana's been denied, Jean as well. So guys, it's not a perfect system. And we talked about this in last week's show, how, Medicare created the K-level system just to have something to be able to classify folks and to give some sort of guidelines to these insurance companies. But, we're going on 30 years on this K-level system, and it really isn't consistent. It's not, I mean, even just in my own daily practice and listening to patients and viewers, I hear some of you like Jim, who had no problem getting his device cleared, right? And other people who are practically doing cartwheels and they're being told that they don't qualify for a higher level device. So I am so grateful to be able to have people like Julie Conley on board in the community who are actively going about putting cases together and doing it, guys. And let me just make this, let me make this one point clear. It's not about getting you the device that you want. It's about getting you the device that you need to get back to your quality of lifestyle. Okay. Yes. Awesome. Let's see. Marianne was denied in the beginning. Pam was appealed, but she won. Keith, not yet. Adam says, I'm a K4BK. Will I still possibly get denied? Adam, it all depends on the insurance company. And again, for me, guys, my knowledge on insurance and approvals and all that kind of good stuff, that is not my strong point. My strong point is gait training and the rehab process and all of that kind of good stuff. So for me, I pick up all my information on what insurance does what, who denies this, how do you get this approved, just from listening to those of you in the community and also listening to the prosthetists out there that I work with. And just seeing how they've been doing it. But, I've seen some cases that get denied that just make me go, who's looking at these claims? My own pebble that I throw into that pond is, like I mentioned, I do a full complement of functional tests so that if the person doesn't necessarily qualify with one of the tests, but they qualify for whatever K level with all the other tests, then we have that supporting documentation. And that's definitely something I can say is the more supportive documentation that you have from your prosthetist, from your physical therapist, and from your doctor, okay, the better your chances are. And Julie is someone who knows what the proper documentation is. And she's somebody who knows how to put it together properly and how to follow the order, the chain of command. Okay. So again, I told Julie, I had a conversation today with Julie about, one of my viewers that I'm referring her to. And I told her, I was like, I'm going to plug you on the show tonight, girl, because you're much needed in this community. So guys, those of you who are struggling right now, pay her website a visit, right? It's for free. And you can just see if there's anything that they can do to help you out. Okay. Megan says, I've been fighting with Blue Cross Blue Shield for 2 years. Mark says his denial was for a diving device. And again, that for me, Mark, bothers me. I mean, I get it. An insurance company will say, if you can walk and you're using a leg for walking, then that's all you need. And I have a problem with that. For me, I'm a very active individual. And part of what keeps me healthy is being active and doing sports. And in my particular case, it'd be running. So if I were an amputee, I would need a specialized running blade in order to stay active, in order to have a better quality of life, and to stay healthy. So for my insurance company to tell me, no, you don't need that, we're not paying for that, yeah, I got a problem with that. And in a perfect world, I want to see that change. And the same thing with diving, swimming, those of you who use a swim fin or a special diving device for when you go inside the water, if that's what's keeping you active, then I say it's going to behoove the insurance company to pay for something like that, right? Rather than pay medical bills down the line because your health is deteriorated because you weren't able to stay active. I don't know. That's just me. Yes, Jim, and also what you have the potential for doing, but therein lies the rub, Jim, right? And this has happened so many times, right? Where I have someone come into my clinic, they are a strong K2 ambulator, but I know that if they had a microprocessor knee, they would be blowing through K3 levels. Now, that's not always the case, guys. There are some folks who are K2 ambulators. They are solid K2 ambulators, and the mechanical knee is the best fit for them. Right? I am not dogging on my mechanical knees. There are some amazing mechanical knees out there on the market, right? But I'm talking about the folks who have the potential to be K3 ambulators if they were given the device, right? So, it's like the chicken and egg scenario. Now, there are some prosthetists out there who are starting to get wise to this and they're able to somehow obtain a practice device. So they're able to obtain a practice microprocessor knee so that their patient can use it and practice on it for a couple of weeks. And the prosthetist can then submit that documentation saying, look, patient was using this for 2 weeks. They were able to move better, less falling, or they tested better on a K level when they used the microprocessor knee. Okay. But then that's the tricky part, is how do you get yourself a loaner knee, right, to test it out? Molly says, as a prosthetist, we work very hard with the physician and the insurance companies day in and day out to get approval. So your prosthetic company will fight hard to get these correct and appropriate components. Yes. And it's prosthetists like Molly that know the vocabulary that needs to be used. They also know that you have to put everything carefully together the first time. Now, can you get appeals and things like, yes, but the best job that you do the first time, the better chance you have of getting it approved, right? And then there's also other entities that I'm hoping one of them will come on the show next year, but other entities that are out there now that are companies that are helping prosthetics clinics in getting reimbursements and getting these for their patients and getting these claims, right? All right. Hey, Carl. All right. So let's move on. Next question. Ooh, here's a good one. So Mark says, are you familiar with PM&R Doctors? And what are your views on them? I love them. I love my PM&R docs. PM&R stands for Physical Medicine and Rehabilitation. So they are a doctor. They go to medical school. And then after medical school, they do 3 years of residency training to become physical medicine and rehabilitation doctors, right? So these are the doctors that you're going to see in your inpatient rehab stays. How many of you guys did inpatient rehab before you went home? Show of hands. Okay. 9 times out of 10, the doctor that's following you inside of inpatient rehab is the physical medicine and rehabilitation doctor, PM&R doc. And then once you are discharged from inpatient rehab, the PM&R doctor will continue to follow you. And from what I see usually happen, Brian says yes, Adam says me. Joanna was also in inpatient rehab. Okay. So we got a lot of responses here. Kenny was, Bonnie was, Pam says nope. Okay. So in PM&R, right, they'll usually follow you after you've been discharged from inpatient rehab. They'll make sure that everything is nice and kosher and working out for you in your life at home. And then either they will eventually pass you along to your family medicine or to your internal medicine or your primary doctor, okay? What I love, and then some people, they continue to see their PM&R docs. Some PM&R docs work as outpatient doctors, right? What I love about PM&R docs is, the R part, the rehabilitation. Right? They're kind of like the physical therapist with an MD behind their name. Okay. So if you've got a physical therapist, occupational therapist, and put it together with an MD, their love child would be a PM&R. Yeah, I just said that. Okay. So these doctors, they know the rehab team, right? They have the full scope. They understand that in order for a person to have a successful outcome after limb loss, after spinal cord injury, after traumatic brain injury, after stroke, right? That they need the full team approach. They need not just the doctor's management. They also need nurse practitioner. They need social worker. They need psychology. They need occupational therapy, physical therapy, vocational rehab. Okay. So the PM&R doc helps put this team together. It helps run the team. I love it when I have a patient who has a PM&R doc, because it means that I just have to focus on the physical therapy part of it, because I know that the PM&R doc is running the show and making sure the person has everything else that they need. Okay. So yeah, huge fan of PM&R docs, huge fan. And not to mention, guys, of all the doctors out there, right? They are the ones that are most familiar with what an amputee goes through after limb loss. Okay. Not dogging on my surgeons, right? But even Dr. Dedesi, the wonderful orthopedic surgeon who came on my show a few weeks ago, said, he goes, with surgeons, right, the surgery is done and the patient comes in for their 6-week checkup. And if everything is good and done, then the surgeon discharges them and then passes them along to the prosthetist, right? The surgeon doesn't typically see the patient anymore after that, right? The surgeon doesn't see the struggles with neuromas, with poor socket fit, with volume changes, with increased weight gain, all of that stuff that happens after, 6 weeks, longer than that, after the limb loss surgery, right? Your PM&R doc does. They do know what's going on, and they know more about sockets. They know more about prosthetic devices. They know more about ordering physical therapy, right? All of that goes on board. Brian Bishop says, 4 years later, and my PM&R doc is still on my team. Linda says, I have, and I continue to see her. Mark says, I asked if he trained with hands-on prosthetic making, and he said yes. Yeah. And I remember when I did a phenomenal, my inpatient rehab was at Baylor in Dallas, and it was my spinal cord rehab internship and wound care. And I remember the rehab doc was everywhere. He was everywhere. He knew all of his patients. And what I really appreciated was that he valued the team, and he valued the input that he was getting from the therapists, from the social worker, from everybody on the team. It's the team approach, and that's the head of our team. Yeah. Then Gregory, I'm not sure. Nope, I don't think I've ever heard of that site. Can you send me that site on a message to my Cozy Talks Messenger? I'm very curious. All right, guys, let's see. There was one other question here from the beginning that I want to make sure I grab. One moment, please. Okay. Brian asks an added question. How common is a neuroma in the first year? I ended up almost a year to the date of getting neuroma surgery and off my leg for 4 months, right after feeling ready to go forward after my first year. So this is where I like to do another COSI poll. Those of you who have had the dubious honor of having a neuroma, how long was it before your neuroma showed up? Or how long was it before you started feeling your neuroma? Okay, so guys, quick ditty. I did actually one of my Did You Know videos this past week on TMR surgery and RPNI. Neuroma is when that nerve that gets cut during amputation starts forming scar tissue at the end of that nerve, and it starts causing a lot of pain. Okay, and as a result, the person is, like I said, in a lot of pain and unable to use their prosthesis normally. Some people can manage it conservatively by getting adjustments made to the prosthesis and sometimes with injections. But oftentimes when the neuroma becomes very painful, it usually requires surgical intervention. Some people get it resected. With resection, however, you have a chance that it's going to come back. Many people now are starting to find out about TMR, targeted muscle reinnervation, where the surgeon takes that nerve ending and plugs it back into the muscle, and neuroma pain is greatly improved, if not completely disappeared. So Johnny says that in that first year, he felt the neuroma. Brian says 10 to 11 months. Hey, Stephen, glad you could join us. Pam says 3 years, just had the revision on May 27. So, basically, whenever that scar tissue forms, that's when that neuroma is forming. When you feel it, again, when you have that nerve ending retract back into that soft tissue, it's just kind of luck of the draw where that nerve ending is going to end up. Is it going to stay put and just not cause any trouble? Or is the scar tissue going to form around it, right? And then it's going to kind of start to move around. And then when you put a prosthesis on and put pressure on it, you see stars, right? And Brian has thankfully not had any issues. And guys, here's another note. There's some people walking around with a neuroma that they don't even realize it, right? Because the neuroma formed on the motor nerve, not the sensory nerve. There's two kinds of nerves. You got the motor nerves that tell your muscles to move, right? And then you have a sensory nerve, which gives you that sensation. So when the neuroma forms on the motor nerve, not a problem. Neuroma forms on the sensory nerve, fireworks, right? Okay, that sounds good, Ben Gregory. All right, guys, we got one last question here, and this one's a good one. This question actually was last week, and I wasn't able to get to this question. So this question comes from Melissa. My husband is a bilateral above the knee amputee, and I am a right below the knee amputee due to a motorcycle accident of June 2020. He needs to lose weight and stretch his hip flexors after being in the seated position for over a year so he can start using his prosthetics. How can we do that? He has exhausted his physical therapy visits because he isn't progressing as fast as they'd like. He needs to keep working at home so he can get back to PT, but we don't know how to do that. I had a really tough time with this question. Let's talk about the first part, and then we're going to address that second part. The first part is, how do you stretch out your hip flexors, okay? So hip flexors, guys, right? Big old juicy muscle that comes down the front of your hip, and it's in charge of flexing or bringing your leg up, okay? So the thing is, this big juicy muscle, when the leg is cut off, whether it's at the below the knee or above the knee, the weight of the leg is no longer there to bring your leg down and stretch it out, right? And then obviously you're not walking, because as you walk, right, you're giving this front part a little stretch, whether you realize it or not. Okay, so when a person has been immobile for a long time, in the case of this individual for a year and as a bilateral amputee, typically I recommend that they get examined first by the physical therapist. And here's why. When you have that much of a tight hip flexor, okay, the hip flexor connects to part of your spine back here. It's all connected, all connected. So if someone has been sitting for a long time and they have super duper tight flexors to the point where it's a contracture, right? And you start getting aggressive on that contracture, you can damage the muscle. You can also damage part of the spine and cause back pain. Okay. So again, when it comes to these stretching exercises, it's good to have a physical therapist just kind of lay eyes on you and just see how much of a tightness that you have. Okay. For the most part, for all of my amputees, below, above, unilateral, bilateral, I do recommend some form of stretching. The first kind is when the person can lay on their back, right, on the bed, and they scoot over to the edge of the bed to allow the limb to drop down. Okay. So this part, let me see if I can position this correctly. I usually have the person put their sound limb on the bed with their knee bent, and that takes the pressure off that lower back. And then I have them lower their limb down off the side of the bed. And if I'm feeling particularly like a nice physical therapist, I might put a nice little warm pack on the front of my patient's hip just to kind of get them to just relax a little bit more and let gravity bring the leg down. Okay, that's my favorite way to stretch. The other way, which is effective, okay, is for the person to be face down on their belly. Okay, and some people just from lying face down, they're already feeling a stretch on the front of their hip. Okay, but once again, guys, it can be a little too aggressive. If you're starting to feel back pain when you do this, it means this is not a good exercise for you to do, and you need to flip onto your back. And there are also some people that because they have a particularly larger belly, they may not be as comfortable lying on their belly. But for people who are comfortable lying on their belly, doing this stretch is good. Now, if you find that you're here and you're not feeling a particular stretch, you can always, wow, Bob, you're really bendy. You can prop up onto your elbows, and that will increase that stretch on the front part of the hip. Okay, so that's the quick and dirty on how to do hip flexor stretches. Now, let's go to this next part. So this particular individual is a bilateral above the knee amputee, and apparently they were sent home from physical therapy because he wasn't progressing as quickly. Guys, that's the whole point of physical therapy. How is your patient supposed to progress so that they're good enough to come back to physical therapy? Okay, and this is where I'm calling out my own profession right now. Yes, I do understand that insurance companies will deny continued physical therapy visits if they don't see as fast a progress as they think should be happening, okay? But this is where I put the onus on my professionals, my fellow professionals, my fellow physical therapists. It's our job to continue to petition for our patients. The same way that it's the prosthetist's job to continue to appeal for their patients to get that prosthetic device that they know that the patient needs. It's our job, okay, as physical therapists to get back in the game and to keep appealing. And guys, I have rammed my head against a brick wall back when I was working in hospital clinics that were insurance-based and going back time and time and time and time again to try to get my patients physical therapy. And it is incredibly frustrating, and I get it, okay? But there are courses out there that we can take to learn how to do this, how to better improve our patients' chances. Guys, as a bilateral above the knee amputee, okay, any of my bilaterals, they're looking at a minimum of 24 and a maximum of 48 or more visits of physical therapy. 3 times a week. Let's say the patient's coming in 3 times a week, 24 visits, that's 8 weeks, 2 months, minimum Minimum. That's like the bilateral below the knee who has no complications. Okay. And for my bilateral above the knees, yeah, they're with me for a long time, 4, 6 months, sometimes longer. And that's depending on how their limb volume is doing. Okay. I know, Brett, and I hear that a lot. And that's one of the many reasons I don't work with insurance in my particular practice, because it was impossible. Okay. But guys, this is something that, in order for you to progress, you need that physical therapist. Okay. Now, if this person was a unilateral below the knee amputee, right? You can get the job done within 20 visits. And that's usually a catch number I hear nowadays with insurance company, 20 visits a year. It's reasonable to get 20 visits below the knee amputee. You can get them walking and moving and doing good. But a bilateral above the knee amputee, that's a complicated case. That's a complicated case that needs long-term physical therapy. And that's something that if that kind of a patient walks into your clinic as a physical therapist, occupational therapist, whomever, you need to get on the phone with that insurance company from the very beginning and explain to them, this patient is going to need a lot of visits for a very long time, and start working with that insurance company from the beginning to set the stage. And for them to understand that the progress made is not going to be the leaps and bounds that you see with a unilateral below the knee amputee. And as a physical therapist, get out there, get the literature that supports this for you. There's tons of studies. That's where I get these numbers from, the 24 to 48 visits. There are studies out there to show what is the average length of visit that you can reasonably expect for a bilateral above the knee amputee. So yeah, reading that question, you can tell it got me just a little bit on my soapbox. And guys, like I said, I've been doing this for over 18 years, and I've worked in all sorts of different specialties of physical therapy. Okay. The unifying, frustrating component of all the different specialties of physical therapy, working with insurance companies. Okay. And I'm not saying insurance companies are the devil. I have insurance. They did wonderful things for me when I was going through my own cancer treatment, but it can be very frustrating. It can be extremely frustrating, and you have to get out there and advocate for your patient. As a patient, you need to advocate for yourself. You need to advocate for yourself. If you know that your insurance is only going to give you 20 visits, that very first visit to the physical therapist, you need to talk about a game plan, right? The PT needs to be on the ball about having that game plan ready to get you to where you need to be, okay, as efficiently as possible. And if the physical therapist does not think that they can get you to where you need to be within those 20 visits, then planning starts day one as to how to get you more visits, or how to make it work. Okay. Yeah. All right. Soapbox. I'm getting off the soapbox now. All right. Leanne said, oh, hey, Leanne. Brian says, I was thinking of dating one. What, a physical therapist? I don't know if I'd recommend that, Brian. I'm kidding. Marianne says, I've had a lot more than that, and my guy says it's not a problem as long as I keep progressing. And again, it all depends on the insurance company, okay? So with some insurance companies, as long as you can reasonably document, yes, this patient has demonstrated progress between last week's session and this week's session, this is how they've demonstrated progress. And guys, PTs, we've had this drilled into us in grad school. Okay, because Medicare put a cap on us in the early 90s. Medicare put a cap, no, late 90s, 1997. Medicare put a big old cap on physical therapy and occupational therapy. So at that time, our profession had to get its act together and learn how to document properly as to justifying our services. So we've been doing this for a really long time, right? Ben Gregory, he says, take a deep breath, calm down. Okay, calming down. But no, guys, some insurances, they see that if you provide reasonable documentation that your patient is progressing, right, they will continue to approve the therapy when they see that there is an end goal. Okay. And there are even some cases where the patient may not necessarily demonstrate progress within 1 week. Okay. But there is a reason for that, and that gets documented. Okay. All right, guys, I've done enough soapboxing for this evening. I'm going to go ahead and sign off for this evening. Before I do, guys, please, if you haven't already done so, sign up for my email subscription. Those of you who are signed up will be getting a sneak peek as to my big project launch. The launch date is officially November 3rd, but those of you on that email subscriber list, you're going to get first pick and maybe a little discount to go with it. Just saying. All right. So sign up if you haven't already done so. November 3rd. That's right, Brian. Put it in your calendars. It's my usual Wednesday night, 8:30 p.m. show, and help spread the word for me. I would really appreciate it. All right, guys. As always, if I have not answered your question, please feel free to send it to me in Messenger, Instagram, my website. There, you can find me pretty much anywhere. And I will see you next week. Same bat time, same bat channel. Thank you for letting me be a part of your lives this evening, guys.